Welcome back. Last week we had part 1 with Dr. Jeffrey Dach, and if you haven't listened to that yet, please go back and listen to that first, because otherwise you're going to be picking up in the middle, but you will still get tremendous value from listening in to this one alone, because we talk about so many topics like the value or lack thereof of mammogram. We're talking all about bioidentical hormones, and we're talking about some really important nutrients or hormones that will safeguard your health. So make sure you listen to part 1 and then tune in today for part 2 of Dr. Jeffrey Dach. What about estrogen deprivation, and why does that work?
That question was answered again by the Hungarian pathologist from Budapest, Susanna Suba, and what she says is the both estrogen depletion and estrogen treatment both upregulate estrogen signaling. Estrogen depletion from anti-estrogen drug treatment causes upregulation of estrogen receptors. And to the point where the estrogen receptors on the surface of the breast cancer cells are so upregulated that when the estrogen deprived patient is then given estrogen, and by the way, this was recognized early by V. Craig Jordan, and he writes about this in many of his articles. And the name for this is LTED, long-term estrogen deprivation.
Yep.
And so after long-term estrogen deprivation, either by being menopausal or by taking an anti-estrogen drug, which mimics estrogen, which mimics being menopausal, when estrogen is reintroduced, the upregulation of the estrogen receptors, predominantly ER alpha, will then cause apoptosis of the breast cancer cell, which is programmed cell death.
Programmed cell death, yes.
Yeah, and that's been well described in the laboratory, preclinical studies, and also V. Craig Jordan uses that as one of the explanations of why the Premarin treated group in the Women's Health Initiative had such great results with reduction in breast cancer. So they were long-term estrogen deprived.
Because the average age in that study was 63 and the average age of menopause is 52.
Exactly. So
presumably they had long-term estrogen deprivation.
Exactly. So
and then had estrogen reintroduced.
Yeah, reintroduced estrogen, and whatever little nests of breast cancer cells that are present will undergo spontaneous apoptosis, which is a word which means programmed cell death, programmed cell suicide. And the 3 doctors that received the Nobel Prize in Medicine for discovering that. One was Sidney Brenner, who had a laboratory at Cambridge, and that research was done in roundworms. It turns out that the apoptosis mechanism, molecular gene, is identical in roundworms and humans. It's conserved.
Who knew?
Yeah, it's a conserved gene throughout all of these simple organisms, and so he said he when he received the Nobel Prize, he said that was the eureka moment when his colleague figured out that they looked up the genetic sequencing, and his colleague said it's identical to humans. And that was like a big deal. And the other funny thing about Sidney Brenner, which I have to mention since we're talking about him, he was like known for this like very witty guy. So when he was receiving the Nobel Prize, he mentioned that his wife, when they received word, his wife was in the flower shop doing some shopping, and another lady came up to her and said, "Oh, I heard that somebody with the same name as your husband got the Nobel Prize," because they couldn't believe it. But
Yeah.
he mentioned that, and that was cute.
I like that
So,
story.
apoptosis, estrogen produces apoptosis under those conditions, and the, also testosterone will induce apoptosis. That's not widely known, but testosterone will, for the estrogen deprived patient, the the breast cells will switch to a testosterone alternative pathway, which can also testosterone is known, been studied, and will bind to the estrogen receptor elements on the DNA. So it's like an alternate estrogen.
So, how long is long-term estrogen deprivation?
Uh, V. Craig Jordan says at least 5 years. I think it's probably less than that because one of the studies that was done in breast cancer survivors, where they actually separated them in terms of length of estrogen deprivation, showed that all of the breast cancer recurrences occurred in patients who had less than 2 years of estrogen deprivation. If it was more than 2 years, that group did not have recurrences in that one study. So I would think it's probably, I don't think anybody really knows unless we do more, some serious studies on the matter. But my guess, my speculation is probably 2 years.
So, in young women who get breast cancer, because this really only applies to premenopausal women, because
Right.
postmenopausal women already have that. So, in
Yeah.
young women who get breast cancer,
Yeah.
how do you balance um, the risk of the damage from estrogen depletion to the benefit of long-term estrogen deprivation?
Uh, that's a difficult question to answer. But the thing that I think about is most of the young women in that category, in that who seek medical attention for and are asking for hormone replacement, have already been estrogen deprived. They've been on, a aromatase inhibitor along with a, ovarian suppression drug,
Yep.
and many of them have been estrogen deprived, very severe estrogen deprivation for a period of time, and so I think that's probably long enough for most of them. Very rarely, there's a patient who will have a lumpectomy, with good margins. They're cured, negative axillary nodes, and they will insist on continuing their hormone replacement. Uh, if if they're premenopausal, they will insist on going. A lot of them have already had chemotherapy, which renders them, early menopause,
Right.
and they they will want, they're miserable with menopausal symptoms. They're
Yeah.
miserable, and they
Yeah.
want some relief. And the oncologist, says no. The oncologist is very opposed to the idea of taking hormone replacement, and they insist. They will seek out a physician who can prescribe hormone replacement to them.
I do think that there is a distinction between have breast cancer and had breast cancer.
Yes, of course, and that's a good
And
point. That's a good topic to get into.
And so let's hear your thoughts
You know,
around that.
and we sort of danced around this idea, this topic before. If a patient has active breast cancer, the estrogen is a growth factor. So, uh, you know, we want to look at that as a different scenario, and we don't want to give. We do not want to give growth factors. There are other growth factors. There's TGF beta. There's you know uh, epithelial growth factor,
Yeah.
EGF, and there's a whole list of them. And the
Insulin like growth factor. Yeah.
so here we're talking about treatment for active breast cancer. Mainstream medicine treatment for breast cancer, we all know, is surgery,
Surgery, radiation, chemotherapy,
chemotherapy,
hormone blockade.
et cetera, and then the anti-estrogens as an adjuvant therapy. Then you have integrative oncologists will have a different approach. A lot of them are now using repurposed drugs that have anti-cancer activity. Iodine is an excellent adjuvant treatment, which I think uh, every breast cancer patient undergoing chemotherapy should also be taking adjuvant iodine. Those studies have been done in clinical studies have been done in humans, and they have much better outcomes if they take the iodine. Those studies are done, and
And they fast, and
mhm.
and they fast, right? Like
Yeah, and then
the
the
Warper
they
Longo and
exactly
more stuff that's not
pay attention
trickling
to
down to
those
the,
things. Yeah,
yeah.
and so there are two separate worlds. There's mainstream oncology, and then there's integrative oncology, and you know we I did actually have an entire book devoted to repurposed drug treatment of cancer. Let's see, here it is right here. I don't know if you've seen this one.
No.
Tracking Cancer Toolkit. This came
I
out in
haven't.
2020. And it's 3 pounds, 550 pages.
I
Um,
love that you know how much it weighs.
yeah, well, I carry it around. So it's, you know, you can, do your weightlifting.
It's hefty. That's good
It's,
because we know
and
the importance of lifting heavy things.
yes, heavy lifter. And a lot of the integrative ecology, they're now using, the book came out 5 years ago, really before it became popular. And it's much more popular now, especially ivermectin, which became popular during COVID as an antiviral. It turns out ivermectin is also a very good anti-cancer drug
Yeah.
and very, extremely safe profile. It's uh, and so there are about 300 drugs in the corner drugstore that have anti-cancer activity, and the also 3,000 botanicals. So there's just a lot of these things to choose from, and the big problem is not having enough. The problem is uh, how to put them together in a synergistic way. So that's what we
Yeah.
deal with in the book: how to create synergies so they can use them in combination. And the there's an ebook which is very reasonable, and then the paperback is available. So I do not treat cancer patients in my office. I'm not a cancer specialist. I'm not an integrative oncologist. So, and we do get a lot of calls from patients looking for integrative oncology treatment. And so over the years, when I go to meetings, I make notes, and come across good integrative oncologists. So we've compiled a list over the years, and we provide the list of integrative oncologists to anybody who's interested, and and that's how we deal with patients, looking for that. And By and large, they get very good results. And Rebecca Glazer is, she has her own unique method of treatment with the testosterone and aromatase inhibitors. And For active breast cancer, exemestane is, I think, an excellent drug, along with, there are other growth factors which can be dealt with in addition to estrogen, but, also skin cancers are very sensitive to anti-estrogens because the skin is very hormonal. And so, for active breast cancer, I think exemestane, along with some of the other repurposed drugs, such as fenofibrate, itraconazole, ivermectin, and then for botanicals, you have sulforaphane, sulforaphane, and dipyridamole, which is the platelet inhibitor. Remember, TGF beta is a very big growth factor for cancer, and its platelets are little bags of TGF beta. So most of the TGF beta is in the platelet compartment. So an antiplatelet drug is a very valid anti-cancer strategy. And those studies have been done. Studies on cancer studies using platelets, platelet inhibitors have been done and showing dramatic improvements in outcomes using platelet inhibitors. But anyway, the cancer book is probably topic for a whole separate podcast.
Yeah, absolutely. And then what about people who had breast cancer? Because this is where the rubber meets the road for a lot of people. Because medical oncologists and primary care doctors and gynecologists all have the same attitude towards hormone replacement in women with a history of breast cancer. And it doesn't even have to be hormone positive breast cancer. Like, they think if you had breast cancer, you cannot take hormones.
That's mainstream medicine. That's the dogma, and my approach in my little office, my little universe, is if the patient is, and we review the pathology reports. We want to, for example, if they've had a lumpectomy, we look at the Ki-67. We want a low Ki-67. We want good margins around the nodule. We were interested in the size of the nodule, good margins, negative axillary nodes. That patient should be cured, and is a candidate for hormone replacement, in my opinion. A lot of the breast cancer survivors are patients who've had DCIS, which is has a 98% survival without 10-year survival without treatment, and the treatment of DCIS is really took off when screening mammography was invented in the early 80s, and it's the little punctate calcifications that will trigger a biopsy, and the autopsy study, which I mentioned earlier before when we were chatting, was done in 1980. Was published in 1987 by a pathologist from Copenhagen by the name of Maya Nielsen. She did 110 medical legal autopsies, women, younger women below the age of 50, and she basically did the autopsies looking at breast tissue in a way that emulates screening mammography. So what they did was they did thin sections through the breast tissue, and then did specimen radiographs. So it's like a super mammogram. If mammography was perfect, you would come up with the same findings that she found. They would do the specimen X-ray and then circle where the calcifications were on the slide. They could find it on the slide, and then if you do that, that's like the perfect mammogram technique. If you do that, you'll find what she found, what she reported in 1987, was 20% 22 patients had cancer, breast cancer. 22 out of the 110, which is 20%,
And
had
these
breast cancer.
autopsy studies are women who did not die of breast cancer, obviously. They
They,
died
yeah, they died
of,
of car accidents.
yes.
I think only one patient had a known active breast cancer before death, which came out later. But the out of the 20%, 18% was in situ cancer, breast cancer, and the other 2% was invasive breast cancer. So we know that the incidence of breast cancer is not 20% of the population. So what happens to it's roughly 0.1%, depending on which study you look at. So what happened to the other 19.9% of women?
Yeah.
What happens to them? They don't get breast cancer. So when you do screening mammography, you're finding breast cancer in a reservoir of indolent disease that doesn't become active disease. It's very similar to doing screening for prostate cancer and ultrathyroid ultrasound looking for thyroid nodules. There's all three types of cancer have an indolent reservoir of indolent disease, and then you have a smaller amount that can become very aggressive. So that's one of the problems with screening mammograms, which I'm sure you've come across and that you're familiar with, which is, when you detect DCIS, and 60,000 cases of DCIS are detected every year with screening mammography. There's no reduction in advanced breast cancer or mortality from breast cancer. When you do that, it doesn't contribute to reduction in national mortality of breast cancer. We still have roughly 42,000 women dying annually of breast cancer.
Yeah.
Today, same as it was in 1980, 1970.
Yep.
And
we have not impacted the bottom line at all.
Yeah, so
mammography.
That's one of the reasons why I would guess that you're interested in ultrasound rather than submitting women to screening mammograms.
Right.
I used to read the mammograms, and I was a radiologist at the hospital. I did everything. I did ultrasound. I did angiography. I was an interventional radiologist.
Yeah.
And the other problem with screening mammograms, besides, you have this big problem of overdiagnosis and overtreatment. And of course, the other problem, which isn't discussed much, is the radiation exposure can cause cancer. And, that's overlooked. It's pretty much ignored. But it's probably also another factor to consider.
Are you ready for a breast cancer screening revolution? Well, I'm thrilled to introduce to you a breast cancer screening tool that I have only recently learned about, but I have universally adopted. This is the ARIA test. This groundbreaking at-home breast cancer screening test is one that I believe will completely change the game. So imagine a screening test that's as simple as shedding a tear, because that's ARIA. It's a non-invasive, convenient, and perfect for all bodies and all breasts. Dense breasts, implants, no problem. ARIA makes it clear for everyone, even women as young as 30. ARIA is backed by over a decade of clinical trials, thousands of samples, and it's developed alongside top breast health experts. Here's how it works. You collect a tear sample at home, and then ARIA then analyzes it for protein biomarkers that can signal early breast cancer. And the best part, you get a consultation with a breast health specialist to review your results. Now, ARIA isn't replacing breast imaging. I am using it alongside QT. It's complementing it and giving you a fuller picture of your breast health. Knowledge is power, and ARIA is putting that power back in your hands. It's time to take control of your breast health, and ARIA is another way of doing it. Go to aria.care, AURIA.care, and use my code DrJenn20 in capitals, DRJENN 20 to get 20% off. Back to our show. With without question. But why do you think that that is such? I mean, this has become a an issue of morality, right? Because the facts aren't there. We know that screening with mammogram does not impact survival. It just
Well,
doesn't.
yeah, I mean, then the study that we look at that shows that is the Göteborg, Sweden, the Göteborg mammography clinical trial, which was published in 2003. They found a 20% reduction in mortality from breast cancer. However, there was no reduction in all-cause mortality in that study, and the the fact of the matter is there is no study showing reduction in all-cause mortality utilizing screening mammography, and
Right.
and the uh, and the suggested reason for that is because of the overdiagnosis, overtreatment, which uh, which uh, counteracts the the benefit. The other thing when they look at screening mammography, they find the screened group has a roughly 20% increase in invasive cancer detected compared to uh, the non-screened group.
Yes.
So uh, Gilbert Welch looked at that and published a study on it, and he suggested that what happened to that 22% of invasive cancers in the non-screened group. And so he came up with the idea, well, they must have regressed spontaneously. So that's the idea of spontaneous regression of breast cancer. A lot of it is just, indolent DCIS that never becomes life-threatening, never becomes clinical attention.
Yeah.
And so that's what we're dealing with screening mammography. It's become, it's $8 billion industry. And, when you have entrenched financial interests like that, it's very difficult to change that.
Yeah. And the thing is, the radiologists who are reading, um, they are not necessarily part of that $8 billion industry in that they don't see that they're not motivated by that. They don't realize that they work for employers who are very much motivated by that. So what they see and what they believe is that they are doing their best to diagnose cancer very early in order to prevent progression, prevent being able to give people lesser treatment options. But what they don't know or don't realize, or both, is that, first of all, breast cancer is neither linear nor predictive, right? So if you find something as DCIS, you're assuming that that would go on to become invasive, that would go on to become node positive, that would go on to become metastatic. But that's not the way breast cancer works. It is what it is from the beginning.
Exactly.
It's not a linear progression through a predictable mechanism.
Yeah.
So finding something as DCIS does not save that woman's life, because you have no way of knowing if that was even going to go on to become invasive disease or life threatening. And just having found a small tumor also doesn't guarantee that you are saving that woman's life, because that tumor might not have gone on to become anything at all. Or if it's meant to be metastatic, it's metastatic from the very beginning. So finding small tumors does not impact overall survival. And it also doesn't lessen treatment, because treatment is based on biology. And many of these women, out of fear, go on to have mastectomy,
Yes.
or
Yes.
or because there are multiple things found in the breast and they're kind of exhausted with the evaluation and they just don't want to go through it, or they get a recommendation for mastectomy because there are multiple things found in the breast. And so screening with mammogram has only increased the mastectomy rate by 20%.
Yeah. Of course. Of course. Yeah. It's it's mainstream medicine. It, uh, they're a giant megalopolis. It's controlled by the drug industry. They're not ever going to change, or if they do, it's not going to be in my lifetime. And
I don't think it's going to be
that's a
in
good thing,
mine
because otherwise I'd have nothing to do.
either. We have the exact opposite attitude about this. I'm like, can everyone just see it so I can retire?
Yeah, it's you know integrative medicine. There are two worlds in medicine. There's mainstream medicine, institutional medicine, hospitals, insurance companies, drug industry, and then there's the integrative medicine practitioner, functional medicine, integrative medicine, and they have their own separate types of meetings, and they are a much smaller population, much smaller group, and they see things differently
Yeah.
than mainstream medicine, and thank goodness for that, because otherwise I'd have nobody to talk to.
Oh God. I think I need to put you on speed dial so you have someone to talk to. Okay. I want, before we leave hormones, because I know that we moved on to mammograms, I want to talk about timing of HRT. We touched on breast cancer, and if you are in the category of had breast cancer, you don't have evidence of having breast cancer, you're okay with prescribing those HRT.
I think every patient has to be evaluated, full evaluation, reviewing pathology reports, reviewing all the information, and as we mentioned earlier, Ki-67 is very important. Negative axillary nodes, and good margins on the resection, and also the patient's history, and patients uh, vary quite a bit on a receptivity and how their comfort level in taking hormones after breast cancer diagnosis. So there's a lot, there are all these different factors, and uh, but for the most part, if they're cancer free, you know, uh, in my opinion, they're cured surgically. A surgical cure, which I think happens, is I think, very frequent. I think surgery is a very good treatment for breast cancer, and it can be curable
Yeah.
in patients who do not have metastatic disease. Uh, I'm sorry, you were going to say something.
No, I actually I agree with you, and I think that there are so many people who come to me and say, "Can I reverse this without surgery?"
Yeah,
Um, I think by the time people are presenting clinically, they're the tumor has created its own microenvironment that is a very estrogen rich microenvironment. And again, I am not saying that estrogen causes breast cancer. I want to be very, very clear. It does not. However, once a tumor is there, it does create its own estrogen rich microenvironment.
yes,
And the way that the tumor cells have mutated, they have mutated so that they have upregulated that ER alpha receptor. They have more ER alpha receptors, and that's the way that the tumor continues to proliferate. That is a survival mechanism.
yes.
So, where was I going with this?
Well, you want
This is
to
my
talk
estrogen
about,
deprived brain.
yeah, you want to talk about the how this how does a physician decide which patients to treat with hormones after diagnosis of breast cancer, and it's the differentiation. Do we differentiate between active disease and a patient who's now cured? There's
Yeah.
no active disease. At least we know that 20% of women will harbor uh, either DCIS or invasive cancer, based on the autopsy study by
Yeah.
Maya Nielsen from Copenhagen. But, you know, that's 1 out of 5 women walking around with breast cancer. They have little cancer cells in their breast
Yeah.
tissue.
Yeah. I know
So
where I was going. I just remembered.
okay,
So
go ahead.
people ask me all the time, like, can I reverse this situation without surgery? It is very hard if you have clinical disease to reverse the situation without surgery. I'm not saying impossible. I'm not saying people don't have remissions. They do
Well,
without
Rebecca
surgical
Glazer
intervention.
presents some of those cases that you're talking about, where they do, maybe perhaps it's an elderly patient, or and they decline chemotherapy, and she finds complete regression using her
Yes.
treatment program.
Yes, which she does testosterone pellets along with anastrozole pellets.
Yeah, and for active disease, I think that's reasonable. For
Mhm.
for breast
Yeah,
cancer survivors
absolutely.
without active disease, I think the aromatase inhibitor is probably not a good idea and may actually make things worse. That's based on
So,
a, a study by Soren Kold from, I think he's also from Denmark, and he found that women using vaginal estrogen had a roughly 20% reduction in breast cancer recurrence. However, if they also, these are breast cancer survivors in his study, if they also used an aromatase inhibitor, and he kept track of that, they had a 34% increase in recurrence. So his study was pretty good evidence that adding an aromatase inhibitor onto your hormone treatment for breast cancer survivors leads to great increased, not doesn't help, it makes it worse, leads to increased recurrence. And by the way, we discussed
yeah,
the animal model studies by the professor at El Paso, Texas, Rajkumar Lakshwami. He found the same thing in the animal studies, that adding an aromatase inhibitor made it worse, which goes along with the idea
yeah,
that estrogen is important to maintain the integrity of the genome. And when you block estrogen receptors, you end up with really bad outcomes. The worst outcome that we've ever seen in a breast cancer survival hormone replacement study, which you probably are familiar with, was the HABIT study done in Sweden by
yep,
Lars Holmberg. And in that study, they used estradiol along with a synthetic progestin called norethisterone, which is used in Scandinavia, not used much in the US.
yeah,
But it turned out they had a 300% increase in breast cancer recurrence in the hormone treated group compared to the non-hormone treated group. And so how can we explain that? And the explanation is all of the women with breast cancer recurrence were also taking tamoxifen. So they developed tamoxifen resistance because, remember, when you give a breast cancer survivor a estrogen blocking drug, they switch to the testosterone, the androgen pathway, to maintain estrogen signaling. And guess what? Norethisterone and all the synthetic progestins are testosterone
act like
blocking drugs.
androgen.
So we're blocking both uh, the main pathway with the tamoxifen and the alternative pathway with the synthetic progestin, and that's how you get the 300% increased recurrence. And so, again, that's very supportive of Dr. Suba's thesis that she describes this as the three phases of estrogen resistance. The final phase leading to florid progression of cancer and metastatic disease and early mortality.
Yeah,
And so that's that's all in the book. The the habits study received a lot of attention in the book, and because I think you know it's it's sort of a cornerstone. It's a key to understanding what's going on with breast cancer survivors, and estrogen, anti-estrogen, back, what is the correct thing? What, uh, if
But
you
they
look in the,
only saw that increase in the population that took tamoxifen.
exactly, every patient who had a recurrent cancer was also taking tamoxifen.
Yeah.
And I think it was between 50 and 70% of the patients were on tamoxifen, not all of them, but, and then, there are other few interesting facts about that. All of the patients on Premarin alone, without the synthetic progestin, none of them had a recurrence. None of them.
Yeah.
Uh, and
And that parallels what we found with the Women's Health Initiative.
exactly. And so, when patients or anybody asks me, uh, what caused the increased cancer in the Women's Health Initiative, the 2002 first arm study, it was the synthetic progestin, which is known to be
Yeah.
carcinogenic.
Yeah.
We even have animal models that the where it's called the MPA mouse model of breast cancer. If you go to the university and ask them, well, how do you give mice cancer? They say we inject them with medroxyprogesterone, with
Yeah.
MPA. We inject them with that's the same drug they use in the Women's Health Initiative
Yeah.
study.
Yeah. It's
And
astounding.
you look in the molecular biology literature, and what they found is a progestin is a proliferative brake on ER alpha. However, if you switch to medroxyprogesterone or synthetic progestin, that actually uh, upregulates ER alpha and activates the oncogenes, cyclin D1 and c-Myc, the oncogenes. So that's why there's increased breast cancer, is it activates oncogenes.
Yep.
So that's all in the molecular biology literature, in vitro preclinical studies, which of course, uh, you know, uh, practicing physicians don't have time for that. So
Yeah.
it's nice to put
That's
it in a book.
that's the main problem is that most of the time practicing physicians
Yeah,
don't
they don't have
have the
time; they're busy.
time to
So
do this research.
it's all in the
I
book.
mean, think about
All
how
those
much
studies are in the
time
book.
you yeah, but I took the time to do it. You took the time to write that, but how many practicing physicians are really going to take the time, especially when they truly believe that estrogen causes breast cancer?
Yeah, and then
It would be
they
so
they're
hard for
working
them.
they're working in the insurance model. The insurance model of medicine is,
Yeah.
the insurance company squeezes them, and they get a very small amount per patient, so they have to increase patient volume, which means less time per patient. So they basically have to simplify their evaluation and treatment as simple as possible, and you know they don't really have time for a nuanced, sophisticated look at hormone formulas. They just want to know, can I give this pill? Take this pill every day, or the birth control pack, this little circular pack with the
Yeah.
pills in it. That's perfect for the OB/GYN or mainstream practicing physician, because they just give them the pack and say, follow the directions, and bingo, they're done. They go to the next. They can go on to the next patient.
I know, but then there's the Denmark study of 1.8 million women that shows a direct linear relationship between the time that you're on birth control pills and the development of breast cancer, and it's because of the progestins that are
It's
in the birth
it,
control pills.
the synthetic progestins are carcinogenic, and the birth control pills also are oral estrogens which cause blood clotting. Part of
Yes.
my job as an interventional radiologist, I did the angiograms on young women who had strokes from taking birth control pills,
Yeah.
and it was sad because these beautiful young women, they look like ballerinas, and they're sitting in the waiting room with a paralyzed arm or a paralyzed leg. There's a doctor who did a study on just calculating the number of women taking oral estrogen, including birth control pills, uh, annually, and if they switched to topical estrogen from oral to topical, he estimated that would prevent 3,000 strokes annually in the United States. So, in terms of a public health measure, that that would be a successful public health measure.
Yeah.
If the FDA had an advertising campaign for women, switched from your oral estrogen to topical, and that would be a good idea to advertise that.
Yeah.
And
And just to be clear, so people understand,
yeah,
there is no stroke or clotting risk when you use estrogen topically.
exactly.
It's
And
only with oral estrogens.
instead of that type of useful advertising campaign, what we got was you know a campaign against ivermectin. Are you taking ivermectin? Are you a horse?
Yeah.
Are you a horse?
Yeah.
Campaign, which of course they had to retract that eventually. There was a doctor in Texas who who actually sued the FDA and won against, and they had to retract that ad.
Hello, my beautiful listeners. I'm taking a quick break here to share something truly transformative with you today. If you're ready to take control of your breast health journey, then you need to get your hands on a copy of my book, The Smart Woman's Guide to Breast Cancer. I wrote this book to make a massive impact in the world of breast cancer, empowering women everywhere to make informed choices and educated decisions. You have so much more power and control over your health than you might think. And this book, this is a roadmap to harnessing that power. Inside, you'll uncover the truth about conventional treatments. They're often overestimated benefits and underestimated, underexplained, and underdisclosed long term side effects. But more importantly, you'll discover the true drivers of health and how the choices you make at home every day can lead you to the best health, the breast health of your life, even after a breast cancer diagnosis. Whether you're looking to prevent a diagnosis, avoid recurrence, or simply live your healthiest life, this book is for you. Join me on this journey to empowerment and health. Grab your copy of The Smart Woman's Guide to Breast Cancer today, and let's revolutionize the way that we approach breast health together.
What about timing of HRT in that, is it ever too late? Because I get this question all the time from women who are 60 and women who are 70 and even women who are near 80.
Well, for the cardiovascular protection, the answer to that is yes. But for the other organ systems, it's never too late. And the study that is supportive of that is the million women million women study.
I exceeded my time limit with you.
Well, and that was my office is calling me. They want to know where I am. There's a recent study that was done. They looked at Medicare age women, and they did show tremendous benefits, health benefits, even in the elderly, over the age of 70. And that I think that's understandable. It's reasonable. It's logical, because we know, you have many, all of the major organ systems need estrogen. It's involved in mitochondrial function, bioenergetics. It's involved in genome integrity. It's involved in so many things. And so, yeah, we, of course, the dosage has to be reduced, and, you have to take into consideration the age of the patient. But I think we've seen benefits, even in the these the 60s, the 70s. We we haven't really had very many in their 80s. Just a handful of patients in their 80s.
Yeah.
So usually they've been taking hormones for years, and they just want to continue.
Yeah.
But
Well, we have a mutual colleague, Dr. David Rosensweet, who does in his book talk about a couple of patients who were starting to show signs of dementia
Yeah.
and who did improve with the careful, slow introduction of bioidentical hormones.
Okay. Yeah. That, they, there's tremendous benefit. I mean, we've seen very dramatic improvements in, for example, osteoarthritis. I remember a patient, a pharmacist who, they stand up all day and she had arthritis in her knees and she was having pain.
Yeah.
And we gave her topical estrogen in an oil base to rub into the painful areas of the knees. And within 6 weeks, she was pain free, and she's calling back saying, "No, thank you. I feel so much better." And we've used that topical technique for arthritis patients. Estrogen deficiency causes our osteoarthritis, and the animal studies it's very easy to render an animal estrogen deficient with, surgical removal of the ovaries. And then you can give estrogen back by giving a estrogen pellet to the animal. So they've done all those studies. There are about 40 studies now, animal studies, different animals, showing that estrogen deficiency induces cartilage degeneration and induces osteoarthritis. And you give the estrogen back to the animal, the cartilage will regenerate. And so that's an area that is completely ignored by conventional medicine.
Yeah.
Instead, and that's, we were talking earlier about, what benefits the drug industry. Fear of estrogen the patient will then avoid hormone replacement, develop osteoarthritis, and they become a customer for anti-inflammatory, NSAID, non-steroidal anti-inflammatory drugs.
Yep.
And go to the orthopedic surgeon, eventually get a joint replacement. So that's feeding into the drug industry. More and more profits for the drug industry, more profits for institutional medicine, and you can just go through all the categories. Insomnia. Menopausal women with estrogen deprivation can't sleep because estrogen is needed for sleep. So that they are now a good customer for sleeping pills, which, by the way, are chemically addictive. They get depressed because they have no energy because they're estrogen deficient. So the primary care doctor gives them an SSRI antidepressant. It's more likely that a menopausal woman going to her primary care doctor asking for hormone replacement is more likely, as you mentioned earlier, that they will receive an SSRI antidepressant, which is sad because there's no estrogen in an antidepressant drug, which is what they really need.
Yeah.
And you can just go down the list. I mean, it just keep going.
Yeah. Bisphosphonates, beta blockers, statins.
So
I mean, I can come up with a list of 9 pharmaceuticals without really trying too hard.
You don't have to be a genius to figure out the drug industry profits from the fear of estrogen. So you could call me a conspiracy theorist, but it looks to me like, that's what's going on.
Yeah, for sure. Okay. So here's my last question for you, and then I'll let you get back to the work that you are so inspired to do.
Thank you.
So I have, on a number of occasions, said that I don't believe that breast cancer is a disease of hormone excess. I believe that breast cancer is a disease of hormone deficiency. How do you feel about that statement?
Well, I think you're very correct because 80% of breast cancer is postmenopausal, and 20% is premenopausal. When hormone levels are high, it's only 20%. When hormone levels are low, it's 80%. So, and hormone, if estrogen controls the integrity of the genome, estrogen deficiency is a state of genomic instability, which can lead to cancer. You know, the big question, what causes cancer? A lot of that work was done by a researcher at the University of Nebraska who died in 2021 by the name of Ercole Cavallari. And he studied the estrogen metabolism pathways, and he found that the two estrogen metabolites, 2-hydroxy metabolites, lead to the good pathway. They lead to the 2-methoxyestradiol metabolite, which is actually a anti-cancer drug. It's a microtubule inhibitor type drug. And then the other pathway with the CYP1B1 leads to the 4-hydroxy metabolites, which can then, assuming
We're talking about estrogen breakdown products for all of you
estrogen metabolism.
who don't recognize what we're talking about right now.
This is maybe more technical than your audience is used to, but the 4-hydroxy metabolites then attach to DNA and cause oxidative damage to DNA, which is carcinogenic. So those are the carcinogenic metabolites, normally not present in humans, but under certain circumstances, the 4-hydroxy metabolites can become DNA adducts, and that will cause cancer. And a number of researchers who've looked into this have studied 4-hydroxy metabolites in urine samples, and they will say that it's the most sensitive and accurate marker for breast cancer risk is the presence of elevated 4-hydroxy estrogen metabolites in urine samples. And they've actually found that in breast cancer patients, very elevated levels in the urine of breast cancer patients. So that's an entire area of all by itself. And that to me, that's very convincing as a underlying cause of breast cancer in the population. Genetic abnormalities where you have bottlenecks and accumulation, buildup of 4-hydroxy estrogen metabolites. So when estrogen levels are high and they stay high, you're going to have more estrogen metabolites and the greater chance of bottleneck appearing.
But how does that tie into deficiency?
It doesn't. We're talking about Gilbert syndrome, where they have hepatic genetic abnormality in metabolizing not only estrogen but other drugs.
Mm-hmm.
And then there are other genetic abnormalities in, for example, the COMT enzyme, which is catechol methyltransferase. They have methylation abnormalities, and they can't methylate the metabolites to eliminate them. They end up as 4-hydroxy carcinogen adducts. And so our breast cancer prevention program takes that into consideration. Turns out that iodine is an excellent way to divert the metabolic pathways away from the 4-hydroxy bad ones and towards the 2-hydroxy good ones. So iodine has been studied. That study was done by Stoddard, who worked with the Eskin group, and also DIM, diindolylmethane, which is a broccoli extract. It also affects estrogen metabolism in a very favorable way. So that's part of our breast cancer prevention program. And then Ercole Cavallari published a study showing that both resveratrol and NAC, N-acetylcysteine, are very good at reversing DNA adduct formation and preventing, that whole process. So, I think any physician who's interested in practicing with using bioidentical hormones should be familiar with Ercole Cavallari's work on estrogen metabolites. There's an entire chapter devoted to that and the utilization of iodine and DIM and a few other types of supplements.
We didn't talk about selenium today.
Selenium, the first edition of the hormone Bioidentical Hormones 101, which came out in 2011, there are 4 chapters on selenium, in the first book. The first book, the first edition is free, by the way. Just go to my website. You can and click on books, and you can download a PDF of the entire book for free. Yeah, that's it. And then there are 4 chapters on selenium, and so we do test everyone. That's one on our routine panel, serum selenium. We don't use the lab range. We use a cutoff of 135, which is explained in the book. And, selenium deficiency, the big study was done. It's called the NPC trial at the University of Nebraska. And they recruited selenium deficient patients from dermatology clinics in the Southeast. Turns out that skin cancer patients, a lot of them have low selenium levels. And so about 1,200 patients with low selenium levels below, the average selenium is around 110. And they randomized them, gave them half selenium supplements. And then at the end of I think it was 2 or 3 years, follow-up on selenium, the selenium treated group had 50-60% reduction in all cancers. It was a huge reduction in cancer. And the reason why selenium is so important is because the cancer surveillance system, the DNA repair system in our body, remember, we're constantly we're constantly damaging our DNA just through normal oxidative metabolism.
Through living and breathing.
Reactive, breathing. And so we have a repair system and that's selenoproteins. And so, the BRCA gene women's study, which was done in Poland by Kowalski, shows that if you give selenium to women with BRCA gene mutations, that can reverse the risk of breast cancer to that of their normal siblings. So selenium is huge, and I think it should be routinely tested on every patient. Also the vitamin D is part of our breast cancer prevention program. We know that vitamin D deficiency is increased risk for all cancers, including breast cancer, and higher levels of vitamin D it's a cancer preventive agent. So we do check for that and supplement with vitamin D, and that's we put a lot of thought into the breast cancer prevention, and we do all of those things.
Yeah. Okay, this is really my last question.
Yeah.
For people who don't want to do tamoxifen and don't want to do aromatase inhibition, either they just don't believe in it or they don't tolerate it, what do you say to those people?
If they're coming into the office and they're asking for hormone replacement, if they're postmenopausal, or if they have early menopause, and they're miserable, they have menopausal symptoms, they may have genitourinary syndrome, they may have insomnia from hot flashes and night sweats that wake them up 2 or 3 times a night, and they are seeking relief. And if they're cancer free, based on evaluation of their medical records, they're cancer free. In my opinion, they're candidates for hormone replacement using bioidentical hormones. We want to avoid the carcinogenic progestins, of course, and we also employ the more complete testing evaluation of all those things that we discussed, and have in addition to the hormone replacement, we have an active breast cancer prevention program using the iodine, the DIM, the selenium supplementation if needed, vitamin D if needed, etc. And I consider those patients excellent candidates for hormone replacement.
Amazing.
And again, we discussed this earlier. If the patient has active disease, then they are not. Hormone replacement estrogen is contraindicated, and in those patients, they need careful. They need number one, if it's a nodule that can be removed, they need a lumpectomy. If it's multinodular or a larger mass, then they may need a mastectomy. If they have bilateral disease, then they probably have underlying genetic abnormality, and they're prone to develop breast cancer. They may have some abnormality in estrogen metabolism based on genetic abnormality in one of the enzymes. Like this, the CYP1B1 may be upregulated, and the CYP1A1 downregulated. The ability to methylate is there are people with genetic abnormalities in those enzymes, and there are other genetic things going on. We haven't been looking at estrogen metabolites in detail, although if I was going to do that, if a patient wants to do that kind of a study, I would probably use the lab that David Rosensweet uses, which is the RHEIN lab. They do the 24-hour urine, which I think is pretty good for looking at estrogen metabolites. The downside is, it's an additional fee, and the patient has to carry around a bucket for 24 hours.
It is a little cumbersome.
Yeah. So we haven't really started doing that in a big way.
Okay, we talked about so much today. I just want to try to summarize and make sure that everyone walks away with a clear vision. So estrogen does not cause breast cancer.
Correct.
Breast cancer is much more likely a disease of hormone deficiency. Mammograms don't save lives, and screening with mammograms only leads to 20% more cancer diagnoses. Protection is afforded with iodine, DIM, vitamin D, selenium, and that these are things that everyone should be thinking about taking. Overall, the studies prove that estrogen is protective and leads to a reduced number of breast cancer diagnoses. And for anyone that wants more information, you have a number of books to refer to. So this is the one that I'm reading right now. It's Bioidentical Hormones 101. The previous version from 2014, is that correct?
2011.
2011
Yeah.
is available on your website for anyone.
For free. That's for free. You can just click on there's a menu at the top. Just click on books, the menu selection books. It'll take you to all the lists of the books, and then you'll find the cover of the book with the link on the bottom. For that for the 2011 first edition, there's a link that says download free book.
Okay. And then there's the Cracking Cancer Toolkit.
Yes.
And how do people find you?
My website is jeffrey-md.com.
And Dash is DACH.
DACH. And I also have a free newsletter. Please, everyone should stay in touch with the office by signing up for the free newsletter. It comes out once a month. You can also sign up for the blog, which you get an automatic notification whenever there's a new blog entry. The easy way to do it is just put my name into any search engine, Jeffrey-DACH, and go from there. But you can go to Amazon, put my name into Amazon, and the books will pop up.
Yep, they sure will.
Yeah.
Dr. Dach, thank you so much for spending this time with me and providing all of this invaluable information. I do hope that by putting our voices together, we can impact change, even if it means that you won't have quite as much to do. But there
Uh,
are still always going to be millions and millions and millions of women to help because, as we know, women survive long past menopause, decades past menopause. And we need to change the paradigm. It needs to shift because women and men, everyone needs to have a life worth living. And that often means hormones, and they need to be done safely.
I agree with you 100%. Jenn, it's been a pleasure and an honor to participate with you on the podcast. And thank you so much, for everything that you do. And looking forward, maybe in the future we'll do it again. I'm looking forward to the
We,
next time we have a
we,
chance to do it
we
again.
for sure will do it again. And thank you all for joining us and listening in on this conversation today, because while there are many people who are not ready to hear what we spoke about today, I know that if you're here because you want validation, and I am here to validate you because we're speaking a lot of truths here every single week, and know that I will continue to bring you those truths and to help people to see, because that is my mission. So thank you so much for joining me today. Share it with a friend. Know that I will be back next week, same time, same place. It's Dr. Jenn.